I have noon Eastern Daylight Time. I'm really glad to see so many people here today. I'm Will Meurer. I am an assistant professor of emergency medicine and neurology here at the University of Michigan. I will be also joined by Dr. Lori Gutmann, who is a professor of neurology and vice chair for research at the University of Iowa Department of Neurology. Before we get started with the formal didactic portion of this, I just want to let everybody know that we are recording these presentations and we'll be posting them later onto YouTube. This is just so you know that the stuff in the chat window will be captured and recorded. It's not to say you shouldn't use the chat window. The chat window is going to be our sort of major way for you to provide us with questions. The other functionality about this room that I want to point out is up in the top of the screen. There's a little guy with his hand raised, which allows you to set your status. If you raise your hand, this means that you have a question. As you see my hand, if you look over on the, and that allows us to know that you have a question. We can see that you've raised your hand even though it's not sort of showing for you, and we will try to answer your questions in the order we get them. You can also just go ahead and type a question into this chat area, and then we will work on working answers to those questions in as we present. The other buttons that are available to you up there is if I am talking too fast, you can tell me to slow down, and it will show me a little turtle. If I'm talking too slow, it will tell me to speed up. You can use those if you decide it is necessary, but mostly the way that you'll communicate your questions to us will be through this chat window. So with that, I'm going to just show you a couple other of the functions of our webinar room after talking about our objectives. So at the end of this presentation, the learner should be able to select the trial population and influence how the science and the logistics of selecting the trial population can influence the answers that you will get from your clinical trial. The second major objective is to understand the process of balancing both a population that will be responsive to an intervention, possibly based on prognosis, but will exist in sufficient numbers for inference. And this also gets a little bit to generalizability. So with that, I will give a couple other descriptions of how to use the audience response system. Embedded in our presentation today, we are going to have a couple of questions to poll the audience. You can see there's a thing called the poll in the right lower corner. I will give you a test question first just to see that you're able to use the system. So this is a self-reported outcome, and it may be that you don't really like football, which is fine. But you're to give the votes for your favorite college football team. And I will sort of broadcast my answer. Even though I am a faculty member here in Ann Arbor at the University of Michigan, I was a lifelong resident of Ohio before moving here, so my favorite college football team is Ohio State. After we've given people some chance to answer some of the questions, what we will do is basically switch over to this view where you can see what everybody else has answered. And Lori, West Virginia didn't do so well in this poll. It seems we did get a couple votes for Ohio State, but most people either are not college football fans or I did not list their teams. So anyway, the questions are actually related to the content. So that's what's going on with those, but that's how that uses, and we'll clear all those answers, and then you'll see the next question. All right. So I have no relevant disclosures related to commercial entities, and Dr. Gutmann also has no relevant disclosures. So this is the overview of what we're going to talk about in this session. First, we're going to be talking about population selection. And I'm going to introduce the term enrichment, which you may or may not be familiar with, because I think it actually is what we do when we're trying to select a trial for, or a population for a clinical trial, even if we don't know that we're calling it that. And I think it provides some additional resources for you in terms of thinking about how to think about what population you want to study with the disease. I'm going to go over some major characteristics that are salient to population selection for clinical trials, things that come up consistently with a focus on neuroscience trials. Severity of disease, the age, timing of disease onset are all major categories that cross diseases and are very important to your design of a trial. I will then present a stroke example because not all diseases are acute diseases, and there are many other interesting clinical trials that are going on across the development spectrum. Lori is then going to take things over and give it to you from the perspective of an ALS example. Then we'll talk about some general conclusions and allow for questions. That being said, if at any point in time you have a question, please feel free to use that chat function over there and type a question in over there. And we will try to address. So the disease severity is a very important consideration when picking the right population for a clinical trial. And the absence of conditions that would obscure benefit. And this is something that comes up in many acute stroke trials, the sort of additional exclusion criteria, a neurological or psychiatric condition that would obscure the ability to determine the 90-day functional outcome on the modified Rankin scale. Certainly if somebody had underlying dementia, underlying psychiatric disease that would make it very difficult to do that sort of assessment, that may be a population that you don't want to include in your clinical trial. But this comes at a cost to generalizability later. Any group that you systematically exclude, particularly if you're doing trials that are leading to a FDA regulation of a product, that ends up becoming the sort of parameters for use of that treatment if you find it to be effective later. So you do want to consider these things carefully in terms of what you're putting in and what you're taking out. So there's about three sort of major criteria or major categories that could be used to describe enrichment strategies. And these will, again, seem familiar. This is perhaps a different way of thinking about stuff that you would do when designing a clinical trial somewhat naturally. The first is practical. You want to decrease heterogeneity. Again, this comes at the tension of having a broad population of people with the disease to come up with a generalizable treatment. But it's important to, at least from at the end of the day, this is science and you're conducting an experiment. And heterogeneity of the population and the progress of the disease is going to introduce noise into that experiment. And when there is more statistical noise, there is less ability to detect the effects of your treatment. So the idea of the practical decreased heterogeneity, this tends to be a very straightforward type of process. We'll go into it in a little bit more detail. The other major categories are prognostic enrichment. If you are to do a trial of a treatment, but the risk of having the outcome event is really low, think like a primary prevention of stroke type trial, it would be very difficult to enroll enough patients to detect effects, and the effects would be small. So the likelihood of having the study endpoint is important. So if you were to do a primary stroke prevention trial, then you would want to do it in a population that was extremely high risk for the disease. Or potentially disease processes that can have a particularly large change in an endpoint. If you're looking at the severity of neuromuscular deficits after a spinal cord injury, for example, some of the spinal cord injuries have the potential for a large change in their endpoints afterwards if they're not complete initially. So thinking that if you're using that as your outcome, there's the potential for things to change quite a bit, then that can give you an opportunity to find a population that has room to improve. The idea of predictive enrichment is that there are some patient characteristics at baseline that can sort of show that patients will either respond or not respond to a particular treatment. These can include both patient characteristics, the general phenotype. We could go to age and stroke severity. You could think of, if you're trying clopidogrel, patients who don't have the right cytochrome P450 phenotype to actually metabolize clopidogrel to the active form of the drug to exert its antiplatelet effect. Potentially, when you do a clinical trial, if you were to enrich it and include people who are likely to be responders to clopidogrel, that's a form of predictive enrichment. There's other forms that have disease-specific biomarkers or genomics or proteomics. Obviously, this is something that is happening quite a bit more in cancer these days, in terms of finding people's specific tumor markers and targeting chemotherapy and other agents specifically to those combinations of biomarkers, and even using their responses to the chemotherapy from serial imaging to make decisions about what treatments they should be getting and what treatments are working. That's the idea of the early response of a surrogate. If you're giving somebody chemotherapy to see that their tumor is shrinking, and you're doing MRIs to see that tumor shrink over time, then you get that within patient data that tells you that yes, that chemotherapeutic regimen is actually exerting an effect, and that helps you move the patients into those treatments that are more effective for them within a clinical trial. The downside of both the prognostic and predictive enrichments is, and this maybe is the ultimate sort of final potential pathway of very personalized medicine, is you may be designing treatments that apply to only a small portion of the population. And that, in many diseases, is certainly better than no treatments at all. So I think there are certainly situations where it would be quite appropriate to think about this from the perspective of, having some generalizability issues is okay, especially if this is a condition that we unfortunately have no or few good treatments for. So those are the things to consider when you're trying to build in potentially prognostic or predictive enrichment. So thinking of this from the perspective of decreasing heterogeneity, you want to carefully consider the entry criteria. And again, while the decreasing heterogeneity probably has the least potential impact on generalizability, throwing in entry criteria that you don't have a good biological rationale for is potentially problematic. But potentially, if you know that older patients are very likely to have less predictable disease courses, or younger patients are likely to have less predictable disease courses, it may be better to change that window. In general, my overall approach, taking a step back from a sort of introductory design, would be as many things that you can get quantitative information from your experiments or good epidemiological or preclinical data as you can to make these decisions about who's going to be in your trial quantitatively, I think is very important. Other ways to decrease heterogeneity are methods to find likely compliers with your therapy, and you have to be careful knowing that the general compliance with drug therapies is low, and you want to do this in a way that is well thought out and doesn't absolutely bias the population. But you have to be realistic. If a patient is unlikely to be able to comply with the treatment for various reasons, then they're unlikely to contribute much information to your trial, and that will just, patients who can't contribute outcomes or won't be exposed to the treatment will be increasing the statistical noise in your trial, similarly to the patients who will not drop out. In conditions that have large placebo responses, having a lead-in period where patients are enrolled but the point of randomization doesn't occur until some time. For example, let's say you were considering doing a hypertension trial in the emergency department. Sometimes the blood pressure is elevated in the emergency department, and there may not be much significance to that. If you watch those people for 3 weeks and then sort of collected the ones who were still hypertensive after 3 weeks and then randomized them to various interventions to reduce their blood pressure, that would be a potentially more effective strategy than simply enrolling people at the time of their ED with their ED visit with their isolated elevated blood pressure. Obviously, patients who have a short life expectancy, either from the disease, the target disease, or other comorbid conditions, are unlikely to contribute information in a useful way in a clinical trial that is looking at outcome. There are certainly some situations where patients with a short life expectancy for phase 1 and early phase dose and toxicity finding trials may be appropriate. Obviously, that happens in oncology, and as long as everybody is on the same page that this is a trial that is designed to gather information for future patients and is really not going to contribute much to that patient's outcome, which would be potentially bleak at that point in time. Another major category of ways that you can increase the chances that your trial is going to give you a meaningful answer is ensuring that the probability of having outcome events is likely enough to actually drive the trial in a direction that you're going to be able to make inferences from it. Or, as we talked about, a large change in the endpoint measured in the study. If there's a disease that has degenerative disease that has a well-established natural history, changing the trajectory of the decline in grip strength or some other well-validated marker is a potential strategy that is going to yield you potentially useful results when you're considering who you might be including. You also have to carefully consider the relative versus absolute risk reduction versus the base rate. A 50% relative risk reduction is huge. In a smaller trial, that could mean a mortality reduction from 30 to 15%, which would be a great treatment for any of us, for any of the diseases that we may study that have a mortality rate of 30%. It would also be the same as a mortality change from 1 to 0.5%, which would also be, if it was a disease that affected tens or hundreds of thousands of patients, a very important finding is that could also save many, many lives. Understanding that depending on what sort of early clinical trials that you're doing, it would be very difficult to detect a absolute difference in mortality of 0.5% unless you're using lots and lots of patients. So thinking of what the absolute risk reduction your treatment may engender is important. And if you're choosing patients at high risk, as long as your biological hypothesis is that the treatment ought to be hitting the targets and helping them, focusing first on a high-risk population to say, if I can show that this works in a high-risk population, then perhaps the next step is to apply this to lower-risk patients is a good strategy from the general perspective of the idea of patient selection or enrichment, and that sort of establishing a beachhead of here is a treatment we can use is important. The ideas of predictive enrichment and choosing likely responders. Patients who do not quote-unquote respond to IV TPA following a large vessel occlusion stroke potentially are people who have severe disease and current treatments are not doing as well as perhaps they are in other subtypes of stroke. The disease phenotype, I'm giving a lot of stroke examples, but the hyperdense MCA sign is suggestive of that type of large vessel occlusion over and above what might be seen even in the stroke severity. And obviously, there may be proteomic or genomic markers at baseline that can help you decide if your treatment is going to biologically affect the targets that it's going to affect. So I think the take-home message on population selection, and here soon we'll go into, I think, one more question, and then I'll give a little example about stroke. When we're deciding who to include in a trial, we are doing enrichment at some level. It might not be what we call it, but this is important because it's always a major design step to think about who you are going to be studying after you've decided what the disease is and what the general biology of your treatment is. And again, I've given examples that are a little bit tilted towards drugs, but this is not something that necessarily just applies to drugs. It could be behavioral interventions for patients with alcoholism. It could be behavioral interventions for many other things. It could be device treatments. It could be interventions on physicians in terms of changing physician practice. Obviously, that's something that's hard too. So despite there being a bit of a tilt here towards the drug end of things, I think thinking about the population that you are going to be studying and considering enriching that so that you find this group who you're going to say, if I can show an effect here, there may be other groups later that I can show an effect in, but if I can't find an effect in this group, it will be difficult to find an effect in any group. I think that is really a way to go when you're designing early phase trials. The whole general concept of enrichment in clinical trial design in general, I just want to take a step back and contrast that from the idea of enrichment designs. These are very cool and may be appropriate to some early phase studies in which the design actually helps you learn about the population that's best to study. For example, you're studying a new treatment of stroke. The design can prospectively pick, we should be treating patients with an NIH stroke scale between 5 and 15 who are arriving between 2 and 4 hours of treatment, as those are the most likely ones to respond to this treatment. And this is in distinction to doing sort of retrospective review of data from clinical trials after the trial is done. These things can be built prospectively into designs so that you can pick a population from that design that you would either move forward in a later stage of your clinical trial or in a follow-up trial, and maximize your chance of finding an effect, if there is one, from that treatment. All right, so here is our next question. Which of the following types of population selection strategies will have the lowest adverse impact on generalizability after the trial is completed? Selection of patients based on protein or biomarker, exclusion of older patients, a design that selects out placebo responders, inclusion of most severe patients, or no idea. All right, I'll give everybody another 30 seconds or so to vote. It's okay to put no idea if you have no idea. I'll feel a little bad. Okay, we've got a good number of votes. So I'm going to broadcast the results. So a design that selects out placebo responders, right? Because you don't know if somebody's going to be a placebo responder at the beginning of your study. And saying that, it's not like, and that's not going to go on your package insert. So that's a timing of randomization issue, and it can increase the power of your study. And it should not have a major impact on generalizability. Obviously, if you exclude older patients, you're going to wonder, especially as many neurologic diseases affect the older disproportionately, would the treatment work there? Obviously, that's something that's come up in TPA type trials. So, okay, cool. So I think people are getting that. Okay, so now that we're sort of at the end of the section, are there any questions here? And I was going to go on to a little specific example where I talk a little bit about stroke. All right, I'll take a sip of coffee while people think if they have questions. If you don't have questions, it's fine. We'll have plenty of time later to talk about questions. Okay, I will move on. So before actually we get to the stroke example, in neurologic trial outcomes, we have functional outcomes, and one of the issues here is you're choosing a trial outcome, but it also often has a relationship to age and other comorbidities along with the disease. If you think about the modified Rankin scale for stroke, or even the NIH stroke scale, which is more a measurement of the neurologic exam, there are relationships between how people will perform on these scales with age and potentially other comorbidities. And I think it's important to draw a very clear distinction between the baseline prognosis and treatment effect. When you don't include an older patient in a stroke trial, it's usually not because you don't think there's a treatment effect. It is usually because you believe that their baseline prognosis is poor enough that they're unlikely to contribute information to the trial in a way that will help you detect the treatment effect. And especially if you were to have an outcome of an NIH or a modified Rankin of 0 or 1 in older patients who have large stroke scales, it's very difficult to achieve that completely normal state in that population based on what we know from the epidemiology of the disease. So these key aspects of the population that tend to cut across neuroscience trials are the age, the disease severity and the prognosis, and the onset, the treatment window. Obviously in the acute phase, that's a very short treatment window where the brain ischemia converts over to infarction. In other diseases, the onset of the disease is more insidious, like degenerative diseases, and also the comorbidities are key aspects to be considering when you're selecting the population. And this comes up very frequently for neuroscience trials. So this example of stroke reperfusion, obviously near and dear to my heart. So if you think about this rubric of age, severity, onset to enrollment, and you consider two relatively famous stroke trials, the second ECAS trial and the NINDS TPA trial, here was the approach that was used for what I would argue are the biologically most important baseline prognostic factors in stroke patients who are having acute strokes: age, severity, and onset to enrollments. And then here I have summarized the different inclusion criteria that were, or exclusion criteria that were used. So in the ECAS-2 trial, age went up to 80, and I do not believe it was because that it was felt that people over 80 were not of value in Europe. It was that there was a strong feeling that the treatment effect would be less detectable in that group due to their prognosis. Severity, there was a cutoff, upper cutoff for severity based on potentially imaging, but largely NIH stroke scale in ECAS-2. The NINDS TPA trial did not have a specific top point of do not enroll people over an NIH stroke scale of this or with a severe stroke, although caution was put into the final package insert for patients with quote-unquote severe stroke. Onset to enrollment, and this is probably where the rubber met the road in terms of why these trials came to somewhat different conclusions, was that in ECAS-2, patients were allowed in from 0 to 6 hours, and as many of you know, many of those patients were enrolled after 4.5 hours in that trial, whereas the NINDS TPA trial used a stratification that ensured that half the patients came in at 0 to 90 minutes, and half of them came in at 91 to 180 minutes. And there was a biological rationale for that, in that the brain can only be ischemic for so long, and that the systems of care, EMS, emergency departments, and all of that can be optimized to do this and get patients in early. And if that sort of enrichment strategy hadn't been applied to that trial, it's hard to say, but it may not have come to the same conclusion. So I think these are two well-known trials to many across emergency medicine and neurology, and this is sort of the approach they used to selecting their population. And if you think about how were these potential population parameters related, the age, was there a real biological rationale for age? No. But was it related to the outcome measure? Yes. Severity, there's probably a biological rationale, especially that some strokes are so small that reperfusion is not going to be helpful. And perhaps there are some strokes that are so large that the damage is already done and that reperfusion may also not be helpful. So there was a somewhat of a biological rationale, and obviously that severity affects the outcome measure. And probably of the three of these, the strongest biological rationale is the onset to enrollment, in that brain ischemia is worse the longer it lasts. That is well known from preclinical models, epidemiology, and stroke trials that occurred both before and after these two trials. So if you had to pick anything that was likely to have the biggest chance of helping that idea of onset to enrollment, and in acute neurologic conditions, onset to enrollment is obviously often a key parameter. And you can think a little bit about how well these things correlate with each other. Patients who have really severe strokes often come in faster, so your trial may be enriched in a way that deals with that sort of internal correlation in the epidemiology of disease. I won't talk too much about that, but it's just something to think about, that you ought to get more severe stroke patients in the earlier time window. So in summary, my stroke example, and then I will be asking one question and handing things back over to Lori. You do have this fundamental tension between selecting a population that will have room to respond and then also restricting the population and limiting generalizability. In early phase trials, which many of you are very interested in developing, it usually works better to try to establish that the treatment works in a subset. So establish that beachhead of this is a promising treatment and it works in a subset, but do that prospectively in an experiment that really works for that, as opposed to looking at that post hoc and finding a subgroup, because that is more playing the statistical lottery per se. So you really want to do it in a rigorous way, and then potentially broaden the population later. If you think about the NINDS TPA trial, the ECAS-3 trial that followed that, found that TPA worked in 0 to 3 hours. The ECAS-3 trial allowed further augmentation of that population by finding a continued treatment effect in patients from 3 to 4.5 hours. So with that, I'm going to ask the final question I have, and then I will be handing things over to Lori, and I will mute my microphone and put my camera away, and then you'll get to see and hear Lori. But in the ECAS-3 trial, which one of these exclusion criteria has the strongest biological rationale? So our choices are the combination of prior stroke and diabetes, severe stroke, patient greater than 4.5 hours from onset, age over 80, and not fair, you didn't even present any data from ECAS-3, which is true. I just told you about ECAS-3. So you may or may not be familiar with that trial. It was a TPA trial in Europe that looked at patients who were from 3 to 4.5 hours of onset and treated them with TPA versus placebo. Okay, so I think people are getting this. Oh, I've been broadcasting the results. So everybody saw what everybody else was saying. So that was a good experiment in that people started to see that C was winning and then picked it. So again, this is why you don't look at your data as patients come in your clinical trial. You make sure that you're blinded to that, so you don't decide what the answer is too soon in your trial. But in this worked. I think we got people to one person or a couple people may think it's unfair that I asked about ECAS-3, but as you can see, excluding patients after 4.5 hours from onset has the strongest biological rationale. Combination of prior stroke and diabetes was mainly an epidemiologic epiphenomena that those patients really didn't do well. So that was related to prognosis, not necessarily lack of treatment effect. And it's always a touchy issue when somebody comes in a little late after their stroke and they have this combination of prior stroke and diabetes, because it's one of those things, you know, as a scientist and as a physician who takes care of stroke patients, that combination was put in for purely trial design issues and not really from a biologic rationale, at least that I'm aware of, other than poor prognosis. And we don't really know what the treatment effect is in that population, at least from a nice randomized experiment. So with that, I'll just quickly ask if anybody has any questions for me. And again, Lori we'll have some time after Lori's talk to ask some more questions, although I did go a little long. Okay, I will hand things over to Lori by muting my microphone. And
I hope you can hear me now. I'm going to move the slides forward. Hopefully there's no problems with switching the cameras over. And what I'd like to do is capture some of the points from Will's discussion and review a few more factors important to selection criteria and also apply them to a different disease. So why are selection criteria important? Again, just to reiterate a few points: the safety of the participants in the trial, and also to look at the anticipated effect of intervention to match your population selected, and then for reproducibility of the results and generalizability of the intervention to a population with the disorder. And Will's touched on a lot of these already, but we'll look at them in a slightly different way. And we'll look at them in a little bit more detail as well. So we have our selection criteria. When we develop them, you want the resulting population studied to be a population that's going to benefit from the intervention. As Will talked about before, you want to define your disease. So in other diseases besides stroke, although Will loves stroke, I love a lot of other diseases as well, you could look at multiple sclerosis, and perhaps a population you want to look at to define the disease, and the selection criteria would be to look at patients who had relapsing remitting disease. Or in ALS, you might use the LS-Scorial criteria and have definite ALS as the criteria that you use, or widen that pool to possible, probable, or definite. And you also want to select patients that have a high likelihood that the effect can be detected. Now, maybe that sounds obvious, but it's important to do that. It's important to know what the slope of your expected disease progression is. Are you looking at a change in the slope of the disease, or are you dealing with a stable disease and you just want to look at the outcomes? Expected adverse events will shape your exclusion criteria, and again, this is an issue for the safety of your population. And then you, again, as Will stated, you want to look at the likelihood of adherence or completion of the trial in the population that you select. And if you are looking at competing risks that might obscure the competing risks that might obscure the benefit of your intervention. For example, you would want to put in your exclusion criteria that you don't want patients who have problems with respiratory function to be in an ALS trial as the respiratory disease might progress. So to consider changing a quote from Stan Lee as Superman, or as if you could consider it a quote from Voltaire, with design of a trial comes great responsibility. So the issues that we're dealing with are that neurologic disorders are often rare diseases, and our participants are a precious resource. And you have to keep this in mind in the design of your trial, that we have responsibility to patients who are in the trial as well as outside the trial to ask the best questions possible. So let's talk specifically about ALS trials. ALS trials, time to tracheostomy or death were the original outcome measures in a disease that on average patients only survived 4 years from diagnosis. So having natural history data was important for this disease, and the natural history data was collected over many years. You could look at the slope of the curve from the natural history data, and this allowed for less of a lead-in for studies, especially in a disorder where patients didn't survive for a very long period of time. Lead-in time became precious time is precious time for those participants. And knowing the natural history of the disease, you can look at the standard slope of progression and use that natural history or epidemiological data to find where on the curve you want to catch the participant. Do you want to catch them early in the disease, or do you want to catch them later in the disease? And it depends again on your particular intervention and what outcome measurements you're using. The problem with natural history data is that it can change. Well, how can natural history data change? It changes because we change the way we approach the disease. So no longer are patients with ALS not being placed on, as many patients with ALS not being placed on an intervention such as riluzole. We're being more aggressive with our medical management, and this is in not just in ALS, it's also in stroke trials. Our medical management will change. And this is a slide from a 2009 study, and it looks at survival curves, and just from the trial, Celebrex trial and the creatine trial, these are placebo arms. Just to clarify, these are all 3 placebo arms. And so enrollment started in 1999, in 2000, and then in 2001. And the curve that is farthest to the right and has a less of a precipitous slope, these are all, again, placebo. And the question is, have we changed the way we're approaching? Have we changed the natural history by improving respiratory outcomes, improving nutritional status? Another possibility is that you've just selected a population that's different from the natural history by having patients who want to participate in trials. But either way, you have to consider this, that the natural history data may be different than the old natural history data. Looking for a detectable effect in patients is, again, seems like a no-brainer. That's what we're trying to do, but you need to select a population that will show this particular effect. So are you going to look at time to tracheostomy or death in ALS patients? Are you going to look at the ALS functional rating scale, which shows you change over time? Are you going to look at the forced vital capacity? All of these are validated biomarkers or validated outcomes. And there are new biomarkers that are coming along: electric impedance myography, MRI of the spinal cord, CSF. All of these are potential biomarkers, but you want to look at biomarkers that are validated. And this is important for reproducibility of your results. To look at the effect, you also need to choose by severity. If you have too severe or too advanced disease, especially in a disease like ALS, you might not be able to see any change in the slope of progression. And then if you use survival as an outcome, you may want to choose a population that's not very early in the disease because they may not change. They may survive for an unexpectedly long period of time that would extend your trial significantly. Adverse events and competing risks are also of import when you're looking at your selection criteria. So it's different for ongoing treatments. So in the population that we're talking about, ALS patients, you're talking about an ongoing treatment as opposed to, say, a stroke trial where it may be a one-time treatment or it may be intermittent treatment. And examples of this for adverse events are things like loss of appetite or nausea or hypoglycemia. You would want to avoid patients that had GI disease or patients who had diabetes, because you'd have an increased number of significant adverse events. You might have early withdrawal from the trial because of discomfort. You might even have early death due to weight loss, as we saw in some of the ALS trials, due to loss of weight. These are certainly concerning. So besides adverse events, that might cause increased dropout in your patient population, other things that you need to worry about are competing trials. And so why do you need to worry about competing trials? Well, the participants in clinical trials are more sophisticated. They're going to be looking at other clinical trials, looking at the selection criteria. If you're excluding a lot of patients from your trial, patients may find it easier to be in another trial. And also, if you are having to do a lot of monitoring because of concerns for adverse events, patients may choose an easier trial to be involved in. The last point about being aware of competing trials is also looking at their selection criteria, because it may be important to you. It certainly is important to be able to pool data and make your results more reproducible or generalizable. So when we look at standard selection criteria, we're going to track back a little bit to Will's discussion about heterogeneity and generalizability. So if you're looking at homogeneity or heterogeneity of your population, the latter can help with the results, as Will talked about. I'm not going to reiterate that in the looking at the time, but it can make a comparison between if you make your population too homogeneous, it may change the way you compare your trials, and I'll show you some examples of that in a minute. On the other hand, if you look at this paper by Brian Traynor from 2004, it illustrates survival in a placebo group. So in this case, you think you have a homogeneous population. They're ALS patients. They're in a placebo group. And here, their forced vital capacity, there clearly is more heterogeneity than you expect. And so this can sometimes come out after the fact, that you have a more heterogeneous population than you planned on. And the same thing was seen with maximal voluntary isometric contractions of the arm, that a quote homogeneous population turned out to be a little bit more heterogeneous. And again, these are the things that you can't always predict, and you can look at prospectively. But once you see that in other trials, you need to be aware of it as you design your trial. This is another interesting example, and this comes from a Cochrane review on looking at riluzole and riluzole effect on ALS. Riluzole, for those of you who may not know, is the only FDA-approved drug for ALS. The original trial was in 1994, and the outcome for that showed outcome in survival only. And interestingly, the other outcome measures didn't really show much of a difference. But when you look at this population, there are 3 studies here, and when you look at this study, you can see that the solid lines reflect the top 2 studies that are pulled together, the more homogeneous studies. And red is the treated arm, and blue is the placebo arm. The study that falls out was a specific study that looked at the older population, an older population of patients who had ALS. And you can see that there, the significance between of effect between drug and placebo is much different than it is in the pooled data. If you put that heterogeneous population in with the homogeneous population, you still have a significant difference between placebo arm and treatment arm, but the difference drops. And again, this just illustrates why you may want to look at a more homogeneous population when you're looking for effect of an intervention, as opposed to just opening the intervention to all comers. So back to enrichment. Does it help to focus the population? So in ALS, does it help to look at a really tightly homogeneous population, such as a genetic marker, or how about a population with bulbar onset or limb onset, predominantly upper motor neuron? These groups are going to be much smaller, and they're going to be more difficult to recruit for. But you may want to use these more tightly homogeneous groups to look for a specific effect. And the result of that would be, as Will talked about, the need to repeat a trial with expanded inclusion criteria to try to generalize it to the population. So I'm going to wind up with the question about outcome measures, which we didn't really talk about it as a whole separate talk, but outcome measures that are useful in ALS trials include FVC. You can read those, let you choose. So in this case, I think just the point that I wanted to make is that it's important to look at different outcome measures for your particular trial, but be sure that they're validated outcome measures before you choose them. Otherwise, your results may not be reproducible. And that, especially in a rare disease like ALS, would be very unfortunate to do a whole trial and no one be able to reproduce your results. So in conclusion, to go back to the Bob Temple quote, we don't do clinical trials in a random sample of patients. I think that's probably one of the most important take-home messages and rounds it up in the most basic way. We hope that the webinars helped you consider specific issues in enriching your study population and in the importance of considering selection criteria. These are the slide set, so you can look at these slide sets if you get a chance. There's also a short video from Bob Temple if you want more information on enrichment, and these are quite useful. Thank you. So we will take questions now if there are questions. So we have one question that's coming in. In the meantime, Will, was there anything else you wanted to add? Will, your picture is frozen. So um, Will, I don't know if you're having technical difficulties. I love technology. Can I just say that out loud?
Getting rid of my... Okay, I should be able to talk now, right? People can hear me? Right? Okay. Um, I think in terms of the first question from Dr. Perez, are there resources for trial design help if a PI has a specific question? That is a broad question. I think it depends. I know that there are resources through the CTSI at your institution. Christopher Linzel is very involved in trial design there. Are there resources within the current R25 program? There are, but right now we're scaling that out for the 23 participants we have in the residential course. But there are resources through NeuroNext and processes through NeuroNext, and also for emergency phase trials, the Neurologic Emergencies Treatment Trials Network, and also the StrokeNet for trials that are going on in those diseases to help with protocol development. On to Dr. Conwit's question, and I would like to take the opportunity to introduce Dr. Conwit, who is in the clinical trials office at the National Institute of Neurologic Disorders and Stroke, and is our designated program official, and also our program officer, and one of our core faculty in our course. Can I identify a study that would have been better with more enrichment? I think one of the studies that would be, I tend to use stroke examples. I think potentially the NINDS TPA study could have been better with more enrichment. What if they had flexibly included the possibility of benefit from 3 to 4.5 hours when they had shown it in the earlier phase? That's, I guess, one way that it could have potentially been beneficial. I also think that potentially it's hard to say that when there are neuroprotective trials that have not been successful, could enrichment have shown a benefit and a specific effect if the population had been chosen more carefully? I guess that would be another potential example. But I think the stroke example is a good one in that the follow-up trial that was done ended up happening almost 14 years later. And had there been a design that actually sort of picked the time window as opposed to kind of figuring it out by doing two different approaches in two different trials on two different continents, that might have been better. Let's see. In Dr. Walker's question, in what context has free screening for different amounts of placebo effect prior to randomization been evaluated? To what extent does a patient's prior placebo response predict their placebo response in the future? So that is a great question. We've actually been working with some investigators here in the Department of Psychiatry at Michigan to look at the idea of dose response in placebo. And I can't say that I know the literature very well, but those types of studies are I think really interesting, and there's probably a need for more studies like that. I mean, everybody's somewhat familiar with some of the experiments where big pills have a higher effect than little pills, more expensive pills have a more larger effect than other pills. So whether or not someone's prior placebo response predicts future placebo response is intuitive biologically, but I don't know how well that's been proven, because a lot of times people don't know what they got in that clinical trial in which they were a placebo responder. So there isn't a great way of phenotyping people as placebo responders, because typically their confidentiality within a clinical trial is sort of protected, and you don't typically have a way of linking an individual's identity from one clinical trial to another. Lori, I don't know if you have anything else you wanted to add there. Okay. Let's see, are there more questions? Did I answer everybody's questions so far satisfactorily? I know we're a little bit after 1 o'clock. All right. Well, I think at this point in time, I really want to thank everybody. Oh, Dr. Comet has another. I'll thank people, and then we'll see what additional question Dr. Comet has. Okay, great. Well, thank you for that feedback. I want everybody to enjoy the 4th of July weekend. We will be having our next webinar the Friday after that. Oh, and I want you all, before you leave, there's a link here in the website for an evaluation form. If you click on this, it will bring up the evaluation form for this course to provide us feedback on how we could have made this webinar even better. It's also available on our website, neurotrials.training. So again, thank you everybody for your attention, and I really appreciate you taking a little time this afternoon to spend with us, and we look forward to seeing you at future webinars.